This video has been funded through an educational grant from Biocon Biologics Limited. Biocon Biologics Limited has no input towards the content of the interview or the video. The American Academy of Ophthalmology, or AAO, annual meeting, held in Chicago on the 18th to the 21st of October, welcomed over 15,000 physicians, professionals, and guests. The program included subspecialty days. Retina 2024 had 20 sections featuring a wide range of retinal diseases and treatments, including age-related macular degeneration, or AMD, and diabetic macular edema, or DME. Dr. Sunir Garg spoke with us following the conference to discuss the changes brought by new generations of treatments.
We're lucky that we have a bunch of different treatments and different medicines that we can use for patients with diabetic edema. We know from previous work done by the DRCR network that compared, at that time, bevacizumab, ranibizumab, and aflibercept 2 milligram, that if patients had good visual acuity at baseline, all three drugs were fairly comparable. But in patients who had 20/50 vision or worse, there was a clear advantage to aflibercept 2 milligram. So by the time patients were previously treated with DME and would be enrolled in this study, they probably had cycled through one, two, or perhaps all three of our previous drugs before we would consider switching them to our current agents. And to me, it just kind of goes to show that the potential efficacy of our newer agents, such as aflibercept 8 milligram, does seem to be an advantage over the drugs that we had before. So for most of my patients, if patients came in with worse visual acuity than 20/50, then I would advocate for getting them on aflibercept 2 milligrams from the get-go because the data really is very compelling that patients do much better with that compared to ranibizumab or bevacizumab. I tend not to use bevacizumab for my patients with diabetic macular edema because the efficacy just doesn't seem to be as robust. Or if I do get them there, it takes quite a bit longer to get them that visual acuity improvement that I would like to see. But at least in the US, a lot of insurance carriers are having us start with bevacizumab, and if they don't have an optimal response after a few injections, we can then advocate for our patients to get them onto our desired drug. But for most of my patients, I try to bypass that step if I'm able to.
How are biosimilars changing treatment selections and sequencing?
So biosimilars are a fairly new concept for me, and I think for a lot of retina specialists as well. We're used to having generic drugs, but biosimilars are obviously a different category of drug with the desired outcome being it being functionally interchangeable from the reference product. And currently in the US, there is a biosimilar, two different biosimilars available for ranibizumab. And just recently, there is an aflibercept 2 milligram biosimilar that's become available. And we've started using that to some degree. And right now, it's so new to us that I don't have longer term data on how my patients have been doing with that. And I'm still trying to figure out how that fits into our armamentarium. I've started using it. We have a lot of choices now, which is great. But the question then becomes, when do I consider putting patients on our traditional drugs like ranibizumab, aflibercept 2 milligram biosimilar versus some of my newer anti-VEGF agents, such as aflibercept 8 milligrams or faricimab? Because the data, such as that we presented at the Academy meeting, really suggests that that additional kind of dosing interval is important. And particularly for my patients with diabetic edema, many of them are still working age adults. They may have younger children at home. Perhaps they're taking care of their elderly parents. And by the time they have diabetic edema, I'm usually but one of many doctors that they see. They're seeing their endocrinologist, their primary care doctor. Maybe they have hypertension. Maybe they are on dialysis. Maybe they have foot problems. And so, although it seems like, well, geez, what's the difference between a couple, three shots a year? When you're that patient and you're able to sort of reduce that treatment burden by maintaining your vision so you can still work and drive and come into the office less often, it's a really compelling argument. And so I'm still trying to figure out where the biosimilars fit into my regimen. I'll talk to the patients about the different options available. And I do try to tailor what I'm able to do with what the patient's needs are and what the insurance company, of course, requires us to do. Well, time will tell. I think that the biosimilars and the idea behind them is here to stay. We know that we've seen that in rheumatology, we've seen that in oncology, and presumably there will be a role for them in retina and ophthalmology as a whole as well. And so I anticipate using that. But what's interesting for us, and my brother's an oncologist, and so I hear about this from him, is the biosimilars are great, but at the same time as we have biosimilars, there's ongoing innovation in this space with newer drugs that may be more targeted or have better safety or better efficacy or better durability or different mechanisms of action. They're continuously going to come to market. And so it's a dynamic landscape. And so while I'm delighted to have these drugs, because obviously they're really helpful for patients, to me, it's going to be part of what we do with newer and exciting drugs continually coming to market, such as, the current drugs that we're talking about, as well as newer drugs in the future. So it's pretty cool. And one of the nice things about being a retina specialist is it's really dynamic and evolving, and we learn from each other and try to figure out what's best for the person sitting in front of us. With the data that we have available that's been published on comparing the biosimilar aflibercept 2 milligram versus the reference product aflibercept 2 milligram, they seem to be quite comparable, but obviously that's the definition of what a biosimilar is supposed to do. But I think a lot of physicians like to see what their own personal experience is with it before they're convinced one way or the other. So, from the data that we have available, and this is the large phase 3 study comparing aflibercept 2 milligram to aflibercept 8 milligram, I can say that I can keep patients' anatomy equally good between the two. I can keep their visual acuity equally good between the two. And I can dose aflibercept 8 milligrams less frequently than I can aflibercept 2 milligrams. Now, what I don't have available to me is what happens if I were to do a treat and extend with aflibercept 2 milligram in a similar manner to what we did in the study with aflibercept 8 milligram. We just don't have that data. And so, there's a little bit of, well, how do you do a direct comparison at a 16-week dosing, let's say of aflibercept 8 milligram to 2 milligram? I don't have that available. But anatomically, I've been taking some patients who have been on aflibercept 2 milligram and switching them to aflibercept 8 milligram. And a number of those patients who we were sort of stuck when I was at 2 milligram and I couldn't get them past 8 weeks or 9 weeks, once I've started switching them to aflibercept 8 milligram, I've been able to extend their interval out farther to 10 weeks, 11 weeks, 12 weeks. And so for some of my patients, it's really been very helpful. That's more anecdotal experience. It's not what I talked about at the Academy meeting. But there does seem to be some efficacy difference in at least some of the patients. But time will tell in terms of who would benefit equally well between the two products, who would definitely do better with the 8 milligrams. But based on the data right now, when we're looking to extend patients out further, I'm more comfortable using the 8 milligram dose.
Finally, how is the field embracing innovation and new technologies?
So it always seems like it's a great time to be a retina specialist, but particularly now, there continues to be a lot of advancement in terms of our therapeutics and our ability to treat diseases in a way that's just better for patients, whether it's better results or less frequent visits in the office. We're tackling newer diseases that we never really thought we would have treatments for, such as dry macular degeneration. And hot on the heels of our two FDA approved products, there's a number of new drugs that are in development. So that's always something fun and exciting to talk about. And there's also a confluence with our therapeutics, with our diagnostic abilities in the office as well. We've seen this evolve over the past 20 years, but it really seems to continue to press forward, both in terms of our ability to do at home diagnostics with OCT monitoring, which I think will segue really nicely with our longer acting therapeutics, including our gene therapy that will hopefully be coming, as well as our ability to use AI to analyze images to potentially better forecast the future. Every day I meet patients, particularly those with dry macular degeneration, they want to know what I can tell them about what their vision will be like 3, 5, or 10 years into the future. And although we have some clinical metrics, we don't have a great way to answer that particular question. And I'm hopeful in the years ahead we'll be able to answer that as well. So it really continues to be a very exciting time to be a retina specialist for all that we can do for our profession as well as for our patients.